ACL or anterior cruciate ligament is one of the key ligaments that help stabilize your knee joint. The ACL connects your thigh bone, that is femur, to your shin bone tibia. It most commonly torn during sports that involve sudden stop and change in direction, such as basketball, soccer, and volleyball. When ACL is occur, your knee may swell, feel unstable, and become too painful to bear weight. And for our presentation, we will present about the our patient that have a ACL test grade 2.
My name is Avoni Adi Agedius with the number matrix D201910903223. I will continue with the subjective examination for the athletes. We go for the athlete statement. One football player, that is Fandi Ahmad, with the age of 27 years old, has injured his ACL knee in a football match. The date of assessment for his knee injury was on 20 May 2021. The athlete has talked about his injury to the therapist on how he injured his knee. The athlete said that there was a harsh tackle from the other players and gave impact to his knee. At first, Fandi suspected a meniscus tear, but when the swelling, pain, and unsteadiness didn't go away, Fandi sought advice from a pediatric sport medicine expert, that is Dr. Rachel from the hospital Kuala Lumpur. Dr. Rachel examined Fandi and ordered an MRI for his knee. The radiological image showed Fandi had injured both his meniscus and anterior cruciate ligament, that is ACL, grade 2. For the main complaint, we can ask questions to gain information about the injury. We have to list out the detail from the complaints that the athlete gives. The following question can be asked to the athletes. The first one, how can I help you? Second one, what is the problem? The third one, can you point out where is the location of the pain? The fourth one, will you explain how does it happen? The fifth one, can you tell me when is this happen? Lastly, you can ask what action that triggered this pain. For the pain scale, the visual analog scale were used to measure the injury. As for the symptom of the athlete, the sport therapist preferred that the injury as the number 4 scale in the visual analog scale. It is not a serious injury, but it will take a long time, for about 1 to 2 weeks, to be healed. The athlete can do light exercise and apply an ice pack for the knee to hasten the healing process. Next is the mechanism of injury. An ACL football injury occurs when the ligament is subjected to too much stress. The injury that happened to the athlete is the result of an impact, that is a tackle between the players. The athlete landing or pivoting poorly is also one of the factors occur in the ACL injury. When an athlete's knee turns but his foot doesn't, an ACL tear can happen. We go for the special question. This question will be asked to identify the characteristic of symptoms and patient limitation. The first one, how can you describe your pain sensation? The second one, can you bend your knee while flexing your ankle? The third one, how far can you extend your knee? The fourth one, can you move your knee straight while I give some resistance? Next is the fifth one, does this injury give any effect to your sleep? And lastly, you can ask, do you need help if I give you a low intensity exercise? That is a special question for the patient that you need to ask. Next is the past injury. The injury sometimes happen when athlete occur the same injury in the past. As for sport therapists, we must know how to communicate the patient about their past injury. The first one, when is the injury happen?
It's happened 2 years ago at Penang.
Second one, what caused the injury?
It causes by a heavy impact between my leg and other player when I do tackling in football sport.
Third one, what type of leg injury for the knee that occurred?
It was ACL sprain grade 2 injury. The therapist used MRI modalities to detect the injury.
Okay, we go for the next question. How long it takes to recover?
It was about 6 to 7 weeks to recover and return to the sport.
The fifth question, which side does the injury happen?
It's happened on the right side of the knee.
So for the observation, first observe the patient appearance. Ask the patient to standing and observe the lower limb, especially the leg, where the patient can stand with full weight, partial weight, or with support. Compare the right leg to the left leg. Okay, next is general motor function observation. So ask the patient to sit and then do the extension. So the assessment of motor function can be graded in patient able to obey commands as follows. The right leg compared to the left leg. So there is 0 to 5 grade. For the grade 0 is no movement. For the grade 1 is thicker but no movement. For the grade 2 can move the limb but unable to lift the leg against the gravity. And then the grade 3 able to support the limb against resistance but unable to overcome examiner resistance. So for the grade 4 is mild weakness, the weakly or briefly able to overcome examiner resistance. And for the grade 5, there is normal strength. Normal strength able to maintain the muscle contraction against the examiner resistance. So the next observation is the deformities observation. So for the knee, the patient need to stand with the two feet stuck together to observe for the valgus or varus deformity of the knee. Next is the skin observation. The examiner need to observe the skin around the injured area or knee area and looking for swelling, color of the skin, texture of the skin, the erythematous changes at the skin occurring, vaccination scar, and the superficial cuts or scar. Okay, the last observation is the posture and gait observation. The patient inquire about the difficulty with getting from sitting to standing. Assess the patient walking into planes, which is the coronal and sagittal, from the front and back and right and left sides. Next, observing the patient from the front and looking at the symmetry of gait between stance and swing phase of both legs and the circumduction of one or both legs.
Hello, my name is Spencer. Today I want to show you how to do a palpation for the anterior cruciate ligament. Okay, let's check out this video. For the skin temperature, we palpate the knee joint start by assessing the temperature using the back of a hand and comparing with surrounding the area. For the tenderness, we start with the joint line tenderness. The joint need to be supine position, pressing over the bone of the joint in order to better define joint line and clinician and flag extend the knee, observe where the joint contact points are located. For the medial joint, place the knee into the flag position, a hand position at anterior half of its meniscus and then a rotation of tibia allow for easy palpation medial edge of meniscus. For the lateral joint, we just do the external rotation. This allow to improve position lateral meniscus. Look for knee effusion. Check the suprapatellar pulse and route the knee swelling. Try to push the fluid from the outside to other side from the top to the bottom to feel the swelling in the knee. For the crack fetus, we just click to listen and click and place your hand on the left patella to feel crack fetus during passive movement produced with your right. For the first, place your hand around the front of your knee, so your finger on the back portion of your knee. Find the flexi middle portion of the back middle of your knee. Pressure increasing pressure until you feel compression in the back of the knee. The pulse pressure will feel like a beat, usually steady and even in inertia. Sometimes you may have to press very deep into the popliteal fossa to feel the pulse. Some people have a lot of tissue on the back of their neck.
Thank you. My name is Shirley. I will proceed with tests. There are three types of test range of motion, which is active, passive, and active assistive range of motion. We have the active and passive range of motion test for knee, which is extension and flexion.
First, the active test for knee flexion. The patient will lie supine. Then I'm going to instruct her to bring the heel as far as possible to the buttocks. For extension, I'm going to instruct her to contract the quads or to push the knee in the table. Ideally, the heel will lift off of the table. For passive test, keep in mind that you always start with the unaffected limb before you move to affected one. For passive ROM, in the knee, we will looking at the following movement. For flexion, have your patient in supine position, then grab onto the leg above the ankle. You may also use the other hand to palpate the joint line, and then bring the foot as far as possible to the buttocks. The normal end field of a flexion is tissue approximation. To access extension, fixate the femur above the patella with one hand, and then grab onto the leg above the ankle and perform passive extension. The normal end field for extension is tissue stretch. Next is the stress test. The first one is ligament test, also known as Ritchie or ligament-related test. It is described as the most valid test by a meta-analysis of Benjamin, with sensitivity of 85% and a specificity of 94%. Experts recommend to first exclude a PCL injury before you conduct the test for an SCLT. The reason for this is that the tibia set posteriorly with a PCL injury, which can give you the impression that there is a lot of movement of the tibia when you conduct an SCLT test. So you could have a fall positive in the end. To perform this test, the patient in supine lying position and bring your patient test leg into 30 degrees of flexion. Fixate the femur with other hand, bring the tibia into slight external rotation, and then try to translate the tibia anteriorly. Second is anterior drawer test. The anterior drawer test has a sensitivity of 92% and a specificity at 91%, according to the meta-analysis done by Benjamin in the year 2016. To perform the anterior drawer test, bring your patient hip to 45 degrees and your patient knee to 90 degrees of flexion. You can fixate the position by gently sitting on the foot of your patient. Then palpate the joint line with your thumbs and try to move the tibia anteriorly in an explosive movement. Number 3 is pivot shift test. Basically, the test tries to replicate the sensation or feeling that the athlete has when they tear their ACL. To do this test, we take the heel, put the leg into the internal rotation, apply a valgus stress, and we take the knee from a position of full extension up into flexion. Number 4 is the scolum test. The scolum test examines the integrity of ACL. For scolum test, the patient will be lying supine with the hip flexed at 90 degrees and the knee of 45 degrees. Position the tibia into 30 degrees of medial rotation. The examiner then sit on the patient foot with finger placed behind the tibia and thumbs anterior to the joint, lying to palpate tibial translation, and then draw the tibia forward. Okay, next is sport-specific functional testing and skill performance. We do the trunk power test, which contains 3 types of exercise. The first one is vertical jump. The vertical jump test can be done with a piece of chalk and wall or the vertical jump system. The vertical jump test is considered a measure of explosive and aerobic power. Okay, second we do standing long jump. Regarding the standing long jump, because vertical and horizontal force are active during takeoff and landing, this test may be more stressful than the vertical jump and should be tested later in rehabilitation. And the last one is single leg hop. For the single leg hop, the score is the distance from the start to the location of the posterior heel of the landing leg.
Assalamualaikum and good morning. My name is Liana. Now I will present about my part, that is assessment. Okay, first we go to the active range of motion, that is arm. Arm is joint motion performed voluntarily by the individual through the muscular contraction. The arm indicates the individual willingness and ability to move the injured body part individually. Okay, next is the passive range of motion, that is PROM. In passive movement, the injured limb or body part is moved through the range of motion with no assistance from the injured individual. As PROM is performed, the individual should be positioned to allow the muscle to be in a relaxed state. With the patient prone, assess their available knee flexion, rotate their foot medially as you stabilize your pelvis and palpate the semi-tendinous and semi-membranous on posterior medial aspect. You can also rotate the foot laterally to isolate and palpate the bicep femoris muscle on the posterolateral aspect of the thigh, resistant over the posterior aspect of the distal leg in the direction of the extension. The gravity eliminate elevation places the patient in slight line while the top leg is held up. Palpate all the hamstring muscles as the patient moves off the motion.
For the patient in a seated position, assess their available knee extension. While stabilizing the proximal thigh, palpate the quadriceps muscle as the patient moves through their motion. After flexing the knee slightly, apply resistance over the anterior aspect of the leg in the direction of E flexion. Gravity eliminated version places the patient in side lying. Stabilize the upper leg and palpate the quadriceps muscle as they extend their knee.
Hello, my name is Kelvin Maratin. with no metric D20191087-453, and my part that I will present is about the plan of treatment for the injury. The plan of treatment for the short-term goals first is to reduce pain level of 4/10 VAS to 1/10 VAS within 1 week. For the second is to improve ROM of right knee deflection within 10 degree of the collateral side. Third is to improve the quadricep muscles strength progressively, quadricep index greater than 60%. For the long-term goals, first one is to improve the agility of the athlete within 8 weeks. Second is to improve the speed of the athlete within 8 weeks. Third is to improve the quad muscle strength, quadricep index greater than 80%. Fourth is the athlete able to run in full pace without any pain. And last but not least, athlete able to jump and hop in all directions without any pain. Next, for the plan of treatment for the weekly training phase. For the first week, the training objective is to increase the range of motion and mobility. For the second week, to increase the range of motion, mobility, and regain cardiorespiratory. For the third week, to increase range of motion, regain muscle strength, and improve cardiorespiratory. And for the fourth week, to regain balance, coordination, muscle strength, and improve the cardiorespiratory. For the fifth week, to regain speed, agility, and improve mobility and cardiorespiratory. For the sixth week, to improve cardiorespiratory, endurance, coordination, and also kicking ability. For the seventh week, to improve speed, agility, improve kicking ability, cardiorespiratory, and tactical ability. And the last week, the eighth week, to improve power, muscle, strength, tactical, proprioceptive, and also cardiorespiratory. So we can see that from the first to the third week, the training is more focused on the range of motion and mobility. For the sixth to the eighth week, the training is more sport specific. For example, the kicking ability, the tactical ability, and also the improvement of power, muscle, and strength. For the example of training, I have chosen the week 1 training, which is to improve the range of motion, ROM, and improving the mobility.